for inviting us here today. My name is Vicki Shaw. I'm a doctor by profession, and I'm a jack of all trades and master of none, and have worked in many different settings, including hospital settings, community settings, iwi providers, and youth-specific services. So I think I have an advantage of a kind of understanding how things break down between silos in health. But in recent years, I've had to learn about how that might happen in child, youth and family and education kind of forums and areas as well.
And hi, I'm Helena Watts. I'm the Service Improvement Leader for Central PHO. So the youth team started, or we got the contract to do the youth health services for the Lower North Youth Justice Residential Centre November 2009. I think we were handed over our first bucket of money, and then had to develop that health service from the ground up in a justice facility in Palmerston North. So I guess our presentation today, mostly it's Dr. Vicki Shaw, and I'd like to thank her immensely for putting the presentation together. As a clinical director for the service, she holds the reins really on the ground. All I do is just oversee the contract itself and just make sure that the services are delivered within that contract. So I think I've got the easy job. She's got the much more challenging one. So this is really the journey that we had from starting a health service from the ground up. We were very fortunate to win the Supreme Award at our Mid-Central DHB Awards end of last year, and that was really just the culmination of a huge amount of work from the health team. Collaboration and integration within the sector, with help from the justice facility itself, from the PHO, from our contracted provider, Whakapai Haora, who we subcontract the AOD services. So they provide that service for us. So I'll hand over to Dr. Vicki, as she's known in our service, and we'll just take it from there. Thank you very much.
Or just Doc.
Doc. Okay.
Okay, so I'll just correct a little thing that Paula stated, that when they opened in October 1999, they actually didn't have a health service at all. And they were which sort of subsequently happened in other areas as the Christchurch and the Auckland facilities were opened. They contracted fee for service with whoever would come to the party. And it was probably not really until 2005 that Child, Youth and Family bit the bullet and employed 2.5 nurses who were kind of a little isolated health team. They were all in different sites who were in this great big organisation that was based on social work training and we didn't have the luxury of a health centre in any of these services. So Lower North and Palmerston North was the first facility that was specifically built for young offenders in New Zealand. They took initially both boys and girls into the service, but from 2004 they'd learned quite a lot and they became a male-only service. And some of the learnings were also about that our units were too big and some of the design of our building was not satisfactory. So we're actually in the middle of a rebuild. And that's aiming to bring us into kind of smaller units, but overall will actually increase our capacity from 30 beds to 40. So I guess we're kind of talking small numbers when we can kind of compare ourselves to corrections. So that's our central courtyard, which sort of is roughly still the same at the moment, and all the buildings are kind of around the outside of this courtyard and provide our living areas, our school areas, our swimming pool, our gym, our administration area and our professionals area. Oops. Yeah, right, sorry. So this is the little team of 4. Doc Vicki, Kiwa, our AOD clinician, and our 2 nurses, Hannibal and Linley. And we won the Supreme Award from Mid-Central last year for excellence in innovation and integration in healthcare. So how did we get to this point? And I've got some very bad news to tell you. It took us a decade. All right. So the key kind of organisations, we're not just a multidisciplinary team, we're actually a multi-agency team. from Central PHO and our subcontracted AOD provider from Best Care Whakapai Haora. But in this building, we work closely with Central Regional Health School and Child, Youth and Family. So what was the journey all about? Well, it actually started in the early 2000s when we had something called the Care and Protection Blueprint Investment Strategy that was undertaken, and it was kind of a tiki tour around the country bringing DHBs and Child, Youth and Family officers together to kind of look at improving the access to, in particular, mental health care, but also how that might have kind of impact on residents. And so we had a whole lot that was happening at policy level for quite some time before we got to the point in 2005 where there was discussions between Ministry of Health and Child, Youth and Family to kind of actually look at an interagency project and work out how maybe things could happen better to deliver better health care within residences. And a key kind of issue in that time frame was actually around how was information sharing going to happen. So it wasn't even kind of limited to information between health services. It was also about kind of, there's a whole lot of information that's really valuable sitting in each of these different sectors, and how do we kind of join that up. So there was kind of an initial pilot based in the Care and Protection and YJ facilities up in South Auckland. And then in 2007, they decided they needed to kind of be thinking about national consistency across these residences, and employed myself as a case manager, project manager, and another person down in Christchurch to kind of look at how these models and these kind of ideas might be rolled out. So I'd gone to med school to become a project manager, which I didn't kind of ever think would happen. And it's very, very interesting, because I think I'm probably one of the few doctors in New Zealand who has any kind of concept of how Child, Youth and Family works. And it's kind of one of the key principles that we need to kind of really grab hold of, is that if we're going to work with other agencies, we do need to have key advocates that have spent some time to learn about how the other agencies work, so that we can help each other hear and talk to each other. Really, really important. So that actually went on for another two and a half years, and it was still very much at policy level, but it was also now happening at management level. And I can tell you, one of the things I had to say the most often was to DHB managers that these young men in this facility are your young men. What are you going to do about them accessing care? So you had a whole lot of kind of attitudinal change that actually had to happen before you could actually get people to come to meetings to design the services. We were also starting to kind of support the poor new nurse, that one little nurse who was sitting in the building in a room that was about, 4 feet by 4 feet, providing all the healthcare and trying to kind of coordinate how other providers might be able to come on board to support these young people. And I guess by 2010, which Paula kind of alluded to, we had actually had some really serious conversations happening at DHB NZ level, where the top slicing idea came into part, and money was kind of fed back to the DHBs that had residences to start to kind of do the process of bringing health, funded by health, into the buildings. So that's when my colleague Helena became involved, and I guess regardless of that, from 2007 up until this very moment, we still have to kind of work really, really hard to kind of keep the policy right, to keep the managers informed, because from time to time they all disappear and a new one comes on, and keep the clinical team kind of upskilled and aware as well too. So I mean, we kind of spent quite a bit of energy developing a vision across all three sectors, and came up with the kind of concept that we really wanted to improve the outcomes and the transitions back to whānau and communities for our young people placed in our secure facility. And I guess that's another kind of word kind of issue too, going from the young people at Lower North to our young people in this facility, and that everybody has that kind of attitude. And we also had some key values that were across all three sectors, in school, in child, youth and family, and in our health service. Very much healthy youth development kind of based, So if you're a youth health kind of person or a youth development worker, you'll understand the concepts of connection, confidence, character building and competency. They're key kind of things that underpin everything that we do. We perceive that the young people that are in our building are not necessarily having a negative kind of outcome, that this can be an opportunity for a new beginning for them, and it is not the destination. They're just kind of regaining their focus, their direction, and we're going to support them to kind of get back into their communities. And we know absolutely that our collaborative efforts in total are always going to be greater than our individual parts. So it's kind of that belief that you're going to kind of stick with the collaborative process. So that's a bunch of us from different areas: health, child, youth and family, and Doc Vicki. I don't know how I get into all the photos. And I guess we kind of have these kind of key underpinning requirements that mean that we can function as a multi-agency team, that we have very, very strong commitment to the process. And as kind of pointed out, we've got these kind of shared goals and a shared vision. And we also have a key driver from each of those sectors who kind of help us whenever we get the little hiccups or the bumps. We have communication processes that we kind of continue to fine-tune in terms of kind of making sure that we're sharing relevant and appropriate information in appropriate timeframes. That we have kind of feedback processes, and that we have both formal and informal manners of doing that communication. And as I sort of earlier said, absolutely crucial that we understand the culture of the other agencies, particularly kind of for child, youth and family. If you've never worked with them, you suddenly have to learn about all these kind of legislative kind of requirements, and there are really kind of strict time frames that exist, and there are things that are really important to child, youth and family that might not mean a lot to us in health. But that's kind of how it is. The coordination is really, really crucial, and kind of the basis for that is to kind of keep the young person in the centre of our discussions and our goals, and that we're supporting each other, that we're not undermining, and that we're always flexible. And we've had to be really, really flexible in the rebuild because we've had restrictions on space and opportunities and things. We cooperate very much. It's about kind of designing the transition plan together and being responsible and accountable for the parts that you're going to contribute. And we have a process whereby we kind of review our multi-agency team meeting processes on a regular basis, and we try and endeavour to keep the field social workers involved, and always keeping the young person in the centre of our discussions. We also, from time to time, have the young person actually come along and help direct our kind of discussions, which is always really entertaining. So a little bit about who our young people are. Like I said, we've been 30 beds, we're going to go up to 40, but our young people can come from anywhere in New Zealand, a little bit depending on what the bed status is in the other residences. We average about 170 admissions per year, and just to kind of stress how difficult it sometimes is to kind of actually make any kind of significant health changes, we might have a young person with us for a minimum of an overnight stay, or maybe only a week. Or if a young person is on remand in a case that's in district or high court, they might actually be with us for 2 years. So we have a kind of a huge spectrum of kind of timeframes that we have to work with. Our average length of stay has been 61 days, but the change in the legislation in October last year means that judges can sentence a young person to our service now for an up to 6-month time frame, so that's going to kind of go out in terms of the average duration. Just some little demographics. We only take age 14 to 17. That's a definition that sits in the child, youth and family system, that a young person, a youth, is aged 14 to 17. If you're 13, 12, 11 or 10, you're actually a child, and even if you've offended, you're much more likely to end up in a care and protection residence. We'd rather not have those kids in this setting. And as you can see, the great majority of our kids are 15 and 16, that kind of middle group. And this is just stats from 12-month period starting from June last year. Like the prison service, but maybe a little bit worse maybe, we have over-representation of Māori in our young men, almost 3/4 of them. Where do they all come from? If you kind of look from the red round to the light blue, you can kind of see that most of them are actually from our official catchment area, but we do have maybe about 1/4 that are from South Island, Auckland and Waikato kind of regions. That has changed a little bit for us with the opening of the Rotorua facility. We used to have much more like half of our young people were from Auckland, Waikato, North. Oops, jumping around. And most of our young people with us are on remand rather than actually sentenced. So that's where that short time frame is. And speaking to kind of what Alison raised about, the little green slither there is kind of a recently new thing for us, which is really good. These are young people that are with us rather than being in police cells. So they're with us for a very short time, maybe a weekend until the next court day on the following Monday. So who are actually the people on the ground? Well, in terms of child, youth and family, it's often a point of discussion about describing them as prison warders or correction staff, because they are not. They are under a completely different set of legislation, and our care team are generally youth workers and social workers, and they are employed to manage the daily routines, the behaviours, and they also have a much more kind of youth work, mentoring, role modelling kind of interaction with young people. We have a clinical team who are all social workers, and they kind of operate the case management, and they interface with the family of the young person and their field social worker from the Office of Origin. So that's kind of the communication that might be going back to Hawke's Bay or down to Wellington. We also have a specific escort team. In the past, we used to just employ people any old how, but we now have a specific set of youth-friendly, youth-appropriate people who do the escorts, which includes going to court or to FGCs, but also helps us get young people to health appointments. And Child, Youth and Family has very much a strength-based intervention kind of philosophy with an ICP for every young person, and we're expected to kind of provide information and feed into that and help develop it. They have a structured day. Every young person's in school, but after school hours, weekends and school holidays, there's a constant sort of raft of programs and recreation that's on offer. And we have vocational options for our younger people, particularly our older young people, particularly those that are sentenced, which can include things like getting your chainsaw ticket or your fencing ticket, getting your driver's licence, doing kind of work experience. Central Regional Health School is our school provider, so that, they kind of have branched out a little bit from kind of Wellington Hospital and Palmerston North Hospital and sort of more traditional settings. And they have a relatively large number of teachers, because we operate at a ratio of 1 to 5, 1 teacher to 5 young people. They're all fully qualified, and they use the Te Whare Tapawhā model as their basis for initial assessment and program planning. Once again, they all have an individual education plan, and a lot of that is kind of focused on getting them back to school or further training and education opportunities, or getting them ready for employment when they leave us. And us, well, like we kind of pointed out, 2 full-time nurses, an AOD counsellor at 0.8 of a full-time equivalent, and a 0.4 of me. And kind of our simplification of what we do is we triage the young person as soon as possible on arrival. We operate in the hours of kind of Monday to Friday, 8 till 4:30. So if there's any kind of concerns that the staff have over the weekends, we have a kind of a process that kind of supports them contacting me or contacting after hours service. We endeavour to do a comprehensive health assessment within 7 days, which includes the medical, and some of that is about meeting the criteria that Child, Youth and Family have to operate under, but some of it is also about just making sure that the young people get their health needs met as timely as possible. And our key goals are always kind of getting the engagement of the young person to feel comfortable to come back and see us another time, and also the kind of ongoing health education that's required. We facilitate the access to services, including on our on-site AOD counsellor, but also Central Regional Forensic Mental Health Service. We have had a journey to kind of make mental health care happen in our building, but I can promise you we have a lovely relationship now, and it was worth the 5 years of discussions. And we kind of facilitate the access to off-site. So we've developed kind of good working relationships with our ambulatory care people. We can get young people seen in a very timely manner by specialist services. We have met some of the district health plan girls, so I'll just skip through that. But I guess kind of talking about the mental health care, before 2007 there was no formal kind of support for the service for Lower North, and it was always done on a very ad hoc basis. They'd have an acutely unwell psychotic young person, and then they'd have to kind of work out how they were going to manage it. And there was always that kind of tension between, well, they're safe, they're not running around naked in your community, you can keep them safe, you're not going to let them hang themselves, what's the panic? And I guess then you've got a bunch of social workers and youth workers who are saying, I don't understand any of this, I don't make sense of this. But today, after many, many conversations, we now have Central Regional Forensic Mental Health Service, which is Capital and Coast DHB. Their youth team comes in and provides us cover during the working week with a psychiatrist and psychiatric nurses and other providers. We have a formal arrangement with our local mental health emergency team, and that was sort of an interesting journey as well too, kind of because Child, Youth and Family didn't understand that there wasn't a squadron of them sitting there overnight waiting to come to deliver them. So there was kind of a lot of learning that happened on both sides to make sense of how to manage that, and we now have a really good working relationship. And we also have, because there are no formal forensic youth beds in New Zealand at this point in time, though we're progressing and hoping to get there, we actually have a formal agreement between our local DHB and Child, Youth and Family and Capital Coast about how we might cobble together a solution for that if it should happen. And the funding of all that is none of our business, it's all at DHB level. Physiotherapy. We occasionally used to have young people taken off site for physio pre-2007, but today we just dial our physio and arrange and coordinate a time when they can come on board, and we manage the sports injuries, which as you can imagine with young men and lots of rec, we have a reasonable number of, and also from time to time we have some serious hand injuries that we get our physio involved in. And we fund that through the kind of principally through the ACC contract. Dental, this is something that we're really, really proud of. Pre-2007, there was absolutely no way that our young people could get dental care. And many of them, as you can imagine, hadn't seen the dentist since they were maybe 7 or 8 years old and at primary school. And that was going to be a really hard one for us to solve, but we kind of identified a key advocate for us at DHB level, and then that person helped us connect and find someone who would be an advocate that was respected by the dental community, and she took on herself to locate and find a dentist that would be willing to kind of work with us and come up with a solution. So we have a local private dentist who holds an under 18 scheme contract with the DHB, and he does our dental care for us. And we made it happen because Child, Youth and Family came to the party and said, we'll hire escorts for that afternoon so that you could take 3 kids down to the dentist. So that's how we work. And last kind of time we audited it, we were pretty much 95% of young people that needed dental care, we were getting them seen, which was really cool. That's just a story about a young man, but you guys can read that at your leisure. Yeah, I guess my kind of key message to you is that this takes time to get to this place, and it's not something that you can solve overnight. And I hear what you're saying, that there's people in this audience who've been chomping at the bit and saying these kind of discussions for years and years, but sometimes it's just got to be the right moment for it to happen, and you've got to keep saying what you need to say. Really, really important. And then when it starts to happen, you've got to kind of hang in there and wait for it. And you need it to be happening up here with the policy people, and you need your managers to come on board and make sense of it and understand it, and then you need your coalface workers to feel like that whole structure above them is with them. And you very much need your driver from each kind of sector, and by hell it is worth it. So this is just one of our murals at Lower North in the background, and the key take-home message really is collaborative practice across agencies is difficult to define, impossible to enforce by guidelines, really important that you understand that, but absolutely essential for the best outcomes for high risk, high needs young people. And if you don't like that message, you can have the other one. So thank you.
Thank you very much.